641, and this is my research presentation. For my research project, I'll be looking at the effectiveness of sensory-based functional analyses, or FAs, specifically for identifying the maintaining variables or the modality of reinforcement with individuals that have problem behavior that's been identified to be maintained by automatic reinforcement. So my specific research question is, I'm studying the effectiveness of sensory-based FAs in determining the modality of reinforcement for self-injurious behaviors maintained by automatic reinforcement in order to identify and implement function-based treatment. So just a little bit of information about this topic. Automatic reinforcement is usually used to describe behaviors where the behavior produces the reinforcement itself. So there's no socially mediated reinforcement that's present or at least identified through the typical assessments that we've completed. However, with automatic reinforcement, it's kind of just a broad label. We don't actually know what specific variables are involved with this. So it could be auditory, so perhaps the sound that the behavior is making is what is reinforcing it, or possibly the pressure that is being made by that behavior is what's reinforcing it. There's a number of different things. It's very difficult for people to identify these specific variables as we have no control over them, and there's no way to separate the behavior from them unless you know what those variables specifically are. So then sensory-based FAs, there's a couple different things out there for this, but for this study, we're just going to be looking at blocking different types of sensory input from those specific behaviors and doing that systematically in a alternating treatment design. And then for what people currently use for self-injurious behavior and why it's important to look at this, really we don't have many function-based treatments for automatically reinforced problem behavior, just because we don't typically know what the true function is. Automatic reinforcement is just a very general label that we use. So some common treatments that we see used are the differential reinforcement of incompatible behavior, differential reinforcement of other behavior, sensory extinction, which ideally would be related to the function, the response interruption, redirection, and then the non-contingent reinforcement, which the goal is typically to use the same reinforcement. So if it was, that auditory sound that we mentioned earlier, then we would be providing that sound some way non-contingently to try and decrease the MO for the problem behavior. So we don't have a lot of treatment that really looks at the function. It's a lot more difficult to treat behaviors that are maintained by automatic reinforcement, primarily because of this reason. So we want to look at ways to try and identify those specific variables related to the automatic reinforcement to try and create some kind of function-based treatment and have more effective treatment for these individuals. So for our method sections, we'll be reviewing the participants, the setting, the materials, and then the procedures that will be used. So for participants, we're going to be including 3 participants in this study. In order for someone to be considered to be a participant, they need to have been diagnosed with a developmental disability, and this is really to help with some kind of control over all the different variables that are going to be different between the people. We at least have one commonality, and therefore it can help demonstrate the validity, because it wouldn't just be due to random chance of the participants. There's some commonality between them. And then they also need to demonstrate self-injurious behavior that has been hypothesized to be maintained by automatic reinforcement. So with that, first we want to make sure that we're looking at behaviors that are maintained by automatic reinforcement. We're going to be looking at self-injury just because it's one of the more severe behaviors that are typically maintained by automatic reinforcement. So we want to make sure that we are looking at ways to try and improve the treatment for this. And then we also want to look at whether or not they're truly maintained by automatic reinforcement. So the next little piece on that slide is talking about a standard FA being conducted prior to actually having them be part of the full study, and this would just help rule out any possible social variables to ensure that their problem behavior, the self-injury, is truly maintained by some form of automatic reinforcement. If they were to be find that there are social variables that are maintaining that self-injury, then we would exclude this individual from the study and ensure that we had 3 participants who had the automatic function or automatic reinforcement as a function. And I will explain this FA in the procedure section. So the setting for the entire study will be in a clinical treatment room. We're going to have a one-way mirror looking into the treatment room, and there's only going to be a desk and a chair present, at least consistently across the different conditions. For materials, we want to have a timer to measure the condition durations. That way we can ensure that all of the conditions are the same length. And then for the standard FA, we need to have task materials for the demand condition. And we are going to determine what task materials to use based on, interviewing either the teachers or the parents on what tasks that individual can do, as we don't want to do a skill or a task that they do not have during the demand condition. And then we will include 2 highly preferred items and 2 moderately preferred items that will be determined via preference assessment, which I will discuss shortly. And then we're going to have 4 different colored t-shirts for the therapists to wear in each different condition. So maybe for the for the attention condition, they would wear red. For the demand condition, they would wear yellow. For the tangible condition, they would wear orange. For the other, I can't remember, sorry, we'll go through it. But basically each condition, we want to make sure that they have different colors, and that way we can try and help increase the discriminability between the 5 different conditions, help them pick up on that contingency faster so that we can hopefully get the most accurate results. And then we'll also have a distractor item that the therapist during the intention condition will pretend to be engaged in. So they will, provide that initial statement of just saying that they have some work to do and then turning and doing the tasks, so reading a magazine or reading a book. And then for the sensory-based FA, we will have numbing cream and earplugs, and those will both be used to help block the sensory input that will be possibly coming through from the behavior being demonstrated. So then with the procedure, the dependent variable across the entire study is going to be the frequency of self-injurious behavior. So we're going to be collecting frequency in the standard FA, we'll be collecting frequency in the sensory-based FA, and then in the following treatment for the functional communication training. The independent variables in the study are a little bit different depending on where we're at. The very beginning, technically before the study, where we'll be doing that standard FA to ensure that our participants have automatic function, then we will have the independent variables of those different conditions. So the alone, the attention, the tangible, demand, and control. And then the independent variables for the true study, so what will happen following that standard functional analysis, will be the presence of the numbing cream, the presence of the earplugs, and then the functional communication training being in place. So what we're going to be doing throughout the study from start to finish, we'll begin with the preference assessment. So we're going to be using the multiple stimulus without replacement. We're going to then go on to a standard functional analysis, which we will use different items for those highly preferred and moderately preferred based on the results of the multiple stimulus without replacement. And then we will move on to the sensory-based FA if the participant moves on. And then from there, we would implement functional communication training based on the results of the sensory-based FA. So the treatment design is going to be reversal with an alternating treatment design that we have within the FAs. So the Reversal design for the A phase is actually going to be that sensory-based functional analysis, and B will be the functional communication training. And then for this, the A, or the reversal back to that first phase, we are just going to be looking at whatever condition is related to the identified function. So if it was determined that it was the audio or the audible noise that the behavior makes is what's reinforcing that problem behavior, then we would go back to the condition with the earplugs, as that's what we were assessing in that condition. And then the multiple stimulus without replacement. So the preference assessment, we're going to determine what items to include in this preference assessment based on interviews with parents or possibly teachers or staff, depending on whether they go to school or where they're living. And then we can do some direct observations just when they come, see if they have any things that maybe they're playing with when they arrive, or perhaps if they gravitate towards any specific things in the clinic, then we can kind of include those different items to try and see what they have the highest preference for. If we were to have any difficulties with the individuals scanning the objects, the multiple objects that are laid out in front of them, then we would move down to a paired stimulus preference assessment just to ensure that they're able to pick between those two items. And typically you would see this if, perhaps the individual just keeps picking the item directly in front of them every time, regardless of what it is. And then similarly, if the paired stimulus preference assessment, we saw a strong side bias, we could look towards the single stimulus preference assessment and try to identify a hierarchy there. So then for the standard FA, which is kind of before the assessment or the real research study, but is necessary to ensure that we have the proper participants, we'll have 5 different conditions, and each condition will be 5 minutes in duration. We'll probably have the intercondition time be about 1 to 2 minutes long. And then, as mentioned earlier, the therapists are all going to wear a different colored t-shirt in each condition. We might do attention as red, demand as blue, control as orange, and tangible as green. And we'll keep that consistent throughout each session, and that way we can try and pair that stimulus with that condition, and hopefully they'll be able to understand the contingencies better, and therefore if it was attention that was maintaining that problem behavior, then they would understand that they would get attention for self-injury in that condition more easily, as the therapist is wearing the same red shirt that they did every other time they've gotten attention. So then we will have 2 therapists collect frequency data of self-injurious behavior. Again, that frequency data is our dependent variable, so we'll have that across all of the different conditions and phases. And we will have the 2 therapists collecting throughout the study, and then collect calculate the total count IOA data. So then we will continue the sessions until there's some stability in the data to ensure that we really have a grasp of what that function is. So the different conditions, again, are the alone, where we're going to have the participant be alone in the room. All they'll have is that chair and that table in the room. There won't be any other items. And then all self-injury is basically going to be ignored and then just documented on a frequency count. And then the attention condition, the participant will be in the room with a therapist, but they will have access to 2 moderately preferred items that were determined through the multiple stimulus without replacement, a preference assessment, and they can have free access to those. And then the therapist will tell them, hey, I have some work to do, and then pretend to read and ignore the participant completely unless they engage in self-injury. So if they were making appropriate requests for attention, we wouldn't provide attention following that. They would continue to pretend to read, or perhaps whatever it might be that they're doing. So they would continue on as if they didn't hear that, and then upon the occurrence of self-injury, they would need to immediately provide that attention for about 5 to 7 seconds. And then the demand condition, again, we will have another therapist in there at this time, and the participant will be presented with a demand. Again, it's going to be a demand that they have already mastered so that they can do it independently. However, if they are not doing it independently, the therapist will use the least to most prompting starting with the gestural and then partial physical and then full physical prompt. And then the only time that they would remove the items and stop prompting through would be if there was any occurrence of self-injurious behavior. And following any occurrence of self-injurious behavior, there will be 30 seconds of escape provided. And then in the control condition, the participant will have access to 2 highly preferred items. They will have 5 to 7 seconds of attention every 30 seconds, and then the self-injurious behavior will not result in any kind of consequence from the therapist, so they won't be providing any kind of escape, attention, or access. And one thing with this, with the attention that's being provided every 30 seconds, that will be pushed a little bit further if there were to be self-injurious behavior immediately before. So if, it comes up after 30 seconds, you provide attention, 30 seconds later, it's time for you to provide attention, but the individual engages in that self-injurious behavior, you'll wait another 5 or so seconds before providing that attention, just so that we're sure it doesn't get confused with the attention condition and we don't start to see responding as they might perceive the attention as, or the attention might function as a consequence of that self-injurious behavior if you provide it immediately after. And then the final condition of the standard is the tangible. In this condition, we will have them having those 2 highly preferred items rather than having the pre-exposure. We allow for them to have pre-exposure. In the control condition, which would follow it, or the tangible would follow the control, and they would remove the item, and any appropriate commands for that item or those items would be ignored or denied, and only the self-injurious behavior would result, or the therapist would provide access for. So if they engaged in self-injury, they would provide them access to those items for 30 seconds, and then again take them unless there was another occurrence of self-injury after taking. And then for the sensory-based FA, we will actually have 10-minute conditions. For this one, just because we won't have any specific consequence for the problem behavior other than we will be blocking the sensory input of some type. So again, we're going to have the 2 therapists collect the frequency data of the self-injurious behavior. They'll be doing that through the one-way mirror, and then sessions will still continue until there's stability in the data to ensure that we have control over that data path. And then for the conditions in the sensory-based FA, we'll have 3. The first one will be the alone or control condition in this situation. The participant will be completely alone and they will not have either of those other 2 pieces for the next condition, so they won't have any numbing cream on and they won't have any earplugs. In the second condition, the numbing cream will be applied to the location prior to the start. It will be applied specifically to whatever duration it needs to before it becomes effective, and then the session would begin. And that's for that one. And then for the earplugs, we would place earplugs into the participants' ears before the start of the session and leave them on throughout the entirety of the session. And then in these different conditions, we would see a couple different things. So the numbing cream, if the self-injury was to be hits to the head and I put numbing cream on my head, and if I continue to hit there afterwards, as long as if it persists in the extended 10-minute period, we can hypothesize, depending on what it looks like, whether it is the function or not. It is important, we'll be mindful of a possible extinction burst if it was. So if the numbing cream did actually block the pressure, or if the numbing cream blocked the pressure, which ended up being the function or the modality of the reinforcement, that pressure to that head, we would see it. We would possibly see the rates increase momentarily for that short period of time while we have that extinction burst, or possibly longer, and then possibly drop. The main thing is if rates are higher or lower than the alone condition, it's very likely that there's something going on with the actual function. And then based on the results of the sensory-based FA, we would complete functional communication training, which would be our function-based training or treatment for the self-injurious behavior. So if the results of the FA indicate that the function is access to pressure, which would be determined through the numbing cream, then the participant would work on manding for pressure squeezes. If it was access to noise that was identified, then the participant would have the FCT focus on manding for an audible track that would replicate that noise. So to begin with SET, we would want to start with most to least prompting and then fade to independent, using least to most prompting as needed. With that, since we haven't began this teaching yet, we would definitely need to teach it, and we want to start with errorless learning, which is why we would use the most to least prompting, depending on the specific type of the communication system for the participants. So if they have vocal communication or if they use a PECS card or perhaps a GoTalk, the prompting might look a little bit different. Vocal communication will require the vocal prompting. But if we had the GoTalk or some kind of device, they would use the full physical prompt to begin with and then fade out to there from the partial physical and then to the gestural. And then we would fade that to the independent and then start using least to most prompting for whatever their mode of communication is. And then the functional communication training will be implemented immediately after the sensory-based FA is completed, and we would continue with the FCT until we see stability in the data. So this would be our first B phase. A phase, again, was that sensory-based FA. So then our first B phase would be this functional communication training, and we would want to continue with the B phase until we see stability in the frequency of self-injurious behavior. And then once there is stability in the data, we would return to baseline, which would be our first return to the A phase until we again see stability in the data. And then we would move back to the B phase, which is that functional communication training again. And then we would finish the study once stability in the data is seen again. So this is the AB design. So looking at the treatment designs and why we want to be using these, the alternating treatment design works really well for the FA. It's kind of a standard as we see rapid change between the conditions. It's nice because doing those rapid change, kind of the last bullet point there, will help to ensure the validity of the study and the results. Since we're rapidly changing between those different conditions, we are able to pretty much hold constant the extraneous variables, or at least more so hold constant the extraneous variables across conditions, as there's such short time between them that it's unlikely we would have a lot of those change in that during that session. And then alternating treatment designs is also typically used to compare the different phases, and that's exactly what an FA is intending to do. We're comparing the responding or the rates of the self-injury across those different conditions to see which condition is providing the reinforcement for that, and we would then make a determination on the function. So alternating treatment designs allows for us to do this, and it is therefore one of the best for functional analyses. And then again, just that validity piece is good for the functional analysis, as we can ensure that we had control over the problem behavior. And then a reversal design. In this case, we wanted to use a reversal design over the withdrawal, as we want to make sure we're ending on a treatment phase. Anytime that we're looking at that self-injurious behavior, we would likely want to end on a treatment phase, and especially if it's very dangerous. But just in general, if we're decreasing problem behavior, you want to make sure that you have treatment in place at the end. And then we also prefer it over a multiple baseline design, as we're able to demonstrate control by returning to baseline and removing that functional communication training and no longer providing reinforcement for it. And then the reversal design allows for more replication. So we have the return to baseline and the return to treatment. And then that replication and then the control demonstrated by returning to baseline and being able to either like turn on and off the behavior will add to the believability of the results of the study. And that is all. Thank you.